Hello, everyone. My name is Lindsay Ferkovich-Nelson. Welcome to the fourth webinar in the Speakers Bureau series brought to you by OneSource in conjunction with David Jagrosi. Today, we have Damien Berg presenting Understanding, Adapting, and Planning for Unknown and Ever-Changing Practices in SPD. I would also like to mention the COVID-19 database of essential equipment and news that OneSource has made available free of charge on onesourcedocs.com. And now, Damien.
So first and foremost, thank you all for attending today's webinar. I do want to thank OneSource providing the Speakers Bureau to allow us to talk to you and share the knowledge today. For the attendees, everybody's on listen-only mode, but if you have questions, please type them in the comment box, and our very own David Jagrosi will be moderating it and kind of feeding me the questions after I get completed today with the presentation. So again, thank you very much for attending. And with that, we'll get started. Today's topic is understanding, adapting, and planning for the unknown. I'll kind of give everybody a little secret background here. When we first started working on this and developing content, month and a half, 2 months ago, one of the topics that everybody wanted that we got feedback on was talking about PPE, talking about how are we going to process PPE for this environment that we're living in right now. I've done a few webinars with Amy and Isham, and there's been a lot of webinars done since developing that. And I kind of thought, and I talked to my group and said, you know, I don't think the world's changing, the industry's changing, and practices are changing by the minute. So trying to pare down and say, here is what I want to discuss with you about PPE, or here's the latest standards, it's kind of out there. It's been done. And it's changing so much, I don't want to give information that literally changes the next day. So what I really wanted to do was adapt this presentation to a risk assessment. Because honestly, what we're doing in the world nowadays, what we're doing in sterile processing in the OR, in the hospitals, is really one big risk assessment, because we need to understand that things are changing so fast, and it's not in the standards necessarily. It's not written in guidelines in the beginning. It's all getting there. But what do we do? How do we do things when there is nothing to guide us? And the underlying principle that I want to share with you, that I'm going to share with you today, is a risk assessment. So we need to be able to understand what a risk assessment is, how we do a risk assessment, and more importantly, are we doing it correctly? Because a lot of people think they do a risk assessment, and it's really not a risk assessment. So I'm going to share that with you today, and kind of hope that you leave here with some very usable tools that you can implement right off the bat. So with that, I'll give you a little about me. Again, my name is Damien Berg. I am the Regional Manager of Sterile Processing for University of Colorado Health, or UCHealth. I'm in the Direct Manager of Medical Center of the Rockies and Poudre Valley Hospital in northern Colorado. So I reside about 40 miles north of Denver, large healthcare system. My two hospitals and also a surgery center are what I daily operate. I'm actually sitting in my office at my lunch break right now at 12 noon. So enjoy the view from my office. I've been doing this for about 28 years coming up on now in the OR and sterile processing. I started my venture off at 17 as a combat medic. And as a combat medic, I also worked in surgery. I worked in sterile processing. And that's when I kind of got bit by that sterile processing bug and say, this is what I want to do. One of my last deployments, I moved back to Colorado, and I got a job here at Medical Center of the Rockies when it first opened. So I had to write all the policies, all the procedures, hire all the staff for a brand new level 2 trauma facility. And I realized at that time, I didn't know as much as I thought I did. So I started really immersing myself in the industry at the Isham level, at the Amy level, and really trying to understand what sterile processing is and how it impacts not only people that work it, but the people that receive what we do. So that's where I started my journey. And I've had a little housekeeping. If you're on the line, if you can please mute yourself. Let's take a look here. See. If you're not muted, we appreciate you muting. Oh, I see it. One
It
second
looks
here.
like it's Clemmy Green. So Clemmy, if you're on and you can mute your microphone, that'd be great.
And he's done it. We're good. All right, everybody. You gotta love doing this. Clemmy, can you mute yourself again? There we go. So this is the fun part about presenting in the modern world right now. So in my tenure recently, you can see all the stuff I've done on the screen right there. But the one thing I really do is traveling the country, traveling the world, and really sharing my experiences and meeting people all across this. Doing the new world of COVID, obviously we're doing this all through the web. So it's a good learning opportunity for all of us. And I'm just so happy to be able to share the information for you about risk assessments, why it's important, and what we're doing. So with that, we're going to jump into the meat of this. And the meat is, first one is my disclaimer. So as I told you, I am an employee of UCHealth. So my presentation day does not reflect the views of my employer or my hospitals. I am currently, for another couple days, the immediate past president of ISHM. So again, my presentation view does not represent the ISHM leadership in any way. As well as Amy, as being a co-chair of Amy, I am not speaking on behalf of Amy. This is a Damien Berg presentation, and obviously, finally, OneSource. OneSource is the Speakers Bureau that is putting this on. I do not work for OneSource, and nor am I speaking for OneSource's product, but I am grateful for OneSource to be able to put this on so that we can have such great education. And I'm honored to be the fourth presenter in a line of many great ones that have already been there. So with that, those are my disclaimers. Thank you all. And we'll jump right into the objectives. So the objectives today, it's very simple. I'm going to do a high-level view, and we're going to dig down into some very detailed points on that. And so the first one is going to be reviewing the difference between a risk management, a risk assessment, and risk communication, because there's three different things. A lot of people interchange these. A lot of people think that they're really the same when they're not. A risk management, the assessment, and then the communication piece is really not the correct way to do it. You can't do just one, you got to do them all. The next ones we're going to discuss the development of the risk analysis. That's really important, is to really be able to understand the risk analysis and understand how you implement that. So we're going to dive deep into that. And then lastly, I'm going to kind of share my personal stories here. We're going to describe the benefits of assembling a team to conduct the sterile processing risk assessment. That's really where the meat of this is going to come into. So what is a risk assessment in sterile processing? Who needs to be at the table? What do we need to bring to this risk assessment so that we can really knock it home? Because I've seen in my tenure, in my career, I've seen a lot of risk assessments, and then they identify the risk, they identify maybe what needs to be done out of it, and then it dies right there. It dies on paper, should I say. So we don't want anything to ever die on paper. We want it to be implemented. We want that analysis to be useful to someone so that at the end of the day, they can say, we had some type of decision we had to make. Here's all our facts, and this is how we're moving forward, and this is the way we're going to move forward. And it's be documented. As we know in healthcare, if it's not documented, it didn't happen. So that's going to be the really, really cool thing about this. You'll be able to take that home with you today when you're done. All right. So to dig into it, the really big thing is we're going to review the difference between the three that I told you about: the risk management, the risk assessment, and the risk communication. The really thing about the risk management, and again, there's so many definitions of risk management, but it's a process. So the risk management is overall the entire process when you talk about it. Inside the risk management is your assessing of your risks. You are identifying the risks. You are controlling the risks. And more importantly, you've got to review those controls, because if you don't review them on an ongoing basis, we tend to slip back into a risk scenario, or more importantly, and we'll discuss this later, we tend not to understand if us trying to mitigate a risk caused another risk. So I really want you to understand that sometimes all the best plans and best intentions that we try and we do can really truly fail, just for the simple fact of we thought we had this risk down and we created another one. I'll kind of give a personal story on this, and I'll tie it into some of my later slides. But one of my deployments to Iraq as a medic, we had to work the burn pit. So we would go to this large burn pit, and we got to throw in pretty much everything from biological waste to tires to you name it, food. It was thrown in this burn pit, and this pit burned 24/7. Well, they did a risk assessment at that time, at least that's what I was told, and said, hey, this pit's outdoors, it's far away from everything, you're not really breathing in the smoke directly. They did a risk assessment, and because the risk of having all this trash in the area where soldiers at was greater risk to the soldiers than burning, they said, we need to burn and dispose of this trash. So they did a risk assessment, said burning and disposing of it was appropriate, and the risks of it are these, but they're not that great. Well, years later, we found out that burn pit has caused a lot of problems with people's lungs and their breathing, and I'm one of those who has that now. So the risk management process failed because they did identify the risks, they did assess the risk, they put in some controls, but I personally, Damien, don't believe they reviewed those controls. So they didn't review what they were doing and seeing is there any other byproducts of this that could potentially harm yourself. So that's my personal example. And I'll give you another example in sterile processing that we can relate to on a risk management. So we've all unfortunately had events where potentially bowel burden or a potential bowel burden or something like that made it to the operating room. So what do? We evaluate it, we look at it, but if we never do anything about it, what do we need to do? So identifying the risk is bowel burden in your tray. You assess the risk. What is the bowel burden? Is it blood? Is it tissue? Is it bone? Is it hair? It really doesn't, it matters, but it doesn't matter. You just identify what that risk is, and the risk is to the patient. Your control group is the one you're looking at. What instrument set was it used? So I try to look for common denominator. Was it a loaner set? Was it one we owned? What does it have? Lumen? All this fun stuff. That's my control group, and then I'm going to try to control the risk. How I control the risk is when we have an event like that in sterile processing, it's usually a byproduct of one of three things. One is the staff doesn't have the tools to do their job. The correct brushes, the correct flushing, whatever it might be, proper light for inspection. So I identify, do the staff have the right tools to avoid that bowel burden? That's one of my control. I'm going to control that risk by providing the right tools. The next control for that risk is providing them the correct training and instructions. So do the staff have the IFUs and understand the IFUs for proper disassembling? So do you have access to IFUs inside your decon area so your decon staff knows how to disassemble that set prior to going through your manual wash, your sonic, your mechanical, whatever you might have? So again, identifying that control. So do my staff have the proper training? Do they have the proper tools to do the job? And the last one is, are there any barriers? So is there a barrier? Is there distractions? Is there communication barriers? What's the barrier? Is the barrier we don't have enough sets and I have to rush this tray through? I know none of you have experienced that like I have, but that's the truth. Basically, we know that sometimes we don't have enough instruments. So a risk to that is not enough time. And we don't have enough time to follow the IFUs or properly inspect or properly clean or properly assemble or properly sterilize. That is a control. That's a risk we need to control. So I put all those into place and then we review them. I don't just say I'm done and say we had one bowel burden event and I did all this good stuff and now I'm done. I'm constantly reviewing the controls I put in place. So again, kind of going back to the three things, the tools, the training, and the barriers. Do I have all the right tools? So is there a back order on something? Or more importantly, do I have access? So a lot of us may not have access, whether it be paper access, computer access to IFUs, or who to ask, a trainer, an educator. So I review that consistently with my teams and myself to make sure we are upholding that whole process. And that is identified through ISO 31000. And again, because you don't know what we're working on. So ISOs define this. We define it in sterile processing a little more granular because we know the items we see. So when we talk about risk management, that's where I'm summing it up for you in kind of a whole, egg right there. So you look at the whole thing and say, okay, this is what identifying a risk management process is. Next, we're going to dig down into what risk assessment is. Now, The assessment is a systematic process of evaluating the potential risk that may be involved. Now, I touched on that a little bit. We're going to deep dive into really what this is, but really what is that systematic process? So again, I talked about a little bit what I'm seeing around the country, and I can't see your heads nodding, and that's the one thing unfortunate about a webinar, but I know your heads will be nodding when I say this. The majority of errors and the majority of reasons I see risk or errors in sterile processing is revolved either around lack of time to do your job or vendor loaners coming in late. Also, the staff not knowing how to disassemble them, what proper to inspect, having the right tools to do them. When I investigate errors around the country, or people reach out to me and said, Damien, we have this problem, 8 times out of 10, it's with a vendor or a loaner set. And don't get me wrong, I'm not saying anything bad or negative about our vendor friends. Our vendor friends are amazing. We could not do this job without them. But we got to work as a team. They should be providing us communication of when these things are coming in. So if they're coming in late, not meeting policy, we need to know that, because maybe I can adjust my staffing that day. Maybe I can inform the OR that, hey, this 7:30 start time, the trays aren't coming in until midnight. I got one staff on. Chances of getting them done safely, that's a risk. So I'm gonna assess that really quick on the spot and say, here's a risk, and I'm gonna say, this is what I'm asking to do. Can we bump this case to later? Can we borrow another set? Can we use another set that I have on hand? I'm going to assess those risks and evaluate if we have to continue doing this in the moment with this, what's it going to take? What's it potentially going to do? I always love telling people we can do anything in sterile processing. You, me, anybody, but doesn't mean we should. Doesn't mean we should do anything. So that's where we look at the risk assessment. I'll tie that in now to a little bit of our modern world with the COVID and all the stuff that we have. A lot of talk's been coming around of all the different ways of decontaminating or disinfecting PPE for repeated use. So really the risk for us, guys, if we look at the risk assessment and we look at the systematic processes, the supply chain from the manufacturer of the masks to the supply chain of that individual healthcare system or hospital, and to the please mute your phone if you're on, and to the supply chain process in your own sterile processing department, we may not have enough N95 masks or PPE to continue with the volume we had. And we hit that in our own healthcare system, and I'll talk about that later. But one thing is I took a systematic approach to go, okay, here's the risks of not processing PPE. And when I say processing, disinfecting them for future uses, here's the risk of processing them. So I took a very logical approach, non-emotional approach, and said, here's the best way to either do it. And I want leadership to weigh in, IP to weigh in, legal to weigh in. But I said the risk assessment was all about the potential risks. The potential risk of reprocessing it is XYZ. The potential risk of not reprocessing an N95 is XYZ. And at a certain point, you got to weigh your risks and say, how do we move on with this? How do we overcome this risk and do it smartly? But the next slide I'm going to really talk about really goes into everything we do is a risk assessment any given day. I mean, you drive to work, it's a risk assessment. You do that on a daily basis, but in our world, we have to have a formal approach to it. But now we want to talk about why is it very important to communicate it. So I love this little side right here because it's exactly it. This is how we do things. Communication comes out that we've, got all the parachutes ready, and everybody straps on the parachutes, and they're like, oh, by the way, I didn't tell you, the green is parachute, the red bag is sandwiches. And just like you see in the picture right there, that's a bad day. So when we have small changes, and I can tell you working in 2 large hospitals and a surgery center, this is probably the most challenging part of risk management, risk assessment, is the risk communication. Because everybody sees risk through a different lens. Everybody sees risk. Sometimes people see it very personal. It's risky to me. I can tell you, and I'm sure this has happened in other healthcare facilities, we had people in sterile processing. We also had people outside of sterile processing in the hospital that weighed the risk of working here versus in a COVID environment versus what's my risks at home. We've had staff members whose loved ones are on a transplant list. Well, that makes them inherently a high-risk population. We've had staff members who have young children with autoimmune problems. Well, that's a risk assessment too. So they have to assess that themselves. But how we communicate it is challenging because you got to take that into consideration that everybody's a unique person and everybody has their own vantage point. Are they talking about it as, Damien going home, or am I talking about as Damien as the manager, or am I talking about as Damien as the layperson out there? So it's very much interesting when we look at risk communication. But the key we do it is we become a process for communicating both informal and formal communication for informing our teams about the potential hazards. Because when we don't talk about it, it can make it feel like we're covering up a little bit. I guess that's the easy way of saying it. Again, I've spent 21 years in the military. I'm going to talk how I talk. That's how I've always been. But if you don't communicate and you just push out a process change and you don't give them the why, give the why behind what we're doing, people feel a little bit like you're trying to hide something. And in modern days, when we're talking about the stuff we're doing, when it's not written in an AAMI standard, when ISHM does not have it clearly outlined as a recommendation or a training, a practice, we know there are certain things that we should be doing on a daily basis. And we don't communicate that very well to them. The people will not react very well to it. But what we really need to communicate, and you'll see it on the slide there, is really informing the people about hazards, potential hazards, because all these are potential to their person, their property, or their community. That's what we got to think. What is the risk? So again, when I relate it back to the N95, is the potential hazard is there still COVID or some harm on the mask to the person, to their family, to their coworkers? That's one way of communicating it. If we do nothing and they have no mask or no N95 mask, what are the risks of that? If we reprocess a mask, what are the risks of that? Is the UV light deteriorating the straps? Is the vaporized hydrogen peroxide still reminiscent on there? Is there still some byproduct of that after disinfection and aeration? We don't know. And also is dry heat sterilization or any of the or disinfection, are those changing the fit or the filtration of the mask? These are all properties of hazards we need to research and communicate with the people. You don't want to set up a process and say our risk is we're running out of N95 masks. That's our risk management. We did our risk assessment. Now we're going to communicate it, and our communication is simply we're going to do this process to process PPE or this process to handle bioburden and trace, whatever the risk might be for sterile processing. We don't just define the risk and say, we're communicating, guys and girls, with you. This is how you fix it. We need to give them the why, and we need to give them the variant. I can tell you in my own healthcare system, I had a lot of questions of people, well, why can't we do X, Y, Z? I mean, I'm not kidding you, to the point where I had a surgeon come up to me, or a doctor come up to me and say he's more comfortable putting his PPE in his oven at home for 130 degrees and keep it in there for 3 to 4 hours because he's a doctor and he studies that would kill the COVID, and he can bring the masks and PPE, whatever he wanted to do, bring it back in, because he wasn't communicated with about all the different types that we're looking at, the one that we chose, the why we chose it, and why it's safe for us to move forward with, even if it's not clearly defined in some of the guidance and standards, because we're operating under this weird time. So right now, this weird time is the reason why we need a risk management and understand a risk assessment and understand how to properly communicate the decisions we do around whatever it is. So that's why I spend a lot of time on the risk communication, because I think it's just a vital slide for people to understand. We will go down the wrong path. People will do the wrong thing thinking they're doing the right thing, or they're going to do the wrong thing because they weren't communicated properly, and they're going to buck the system. And that's unfortunate when that happens too. And I don't care whether you're a small 1 to 2 sterile processing person shop or you're a large department, you got to communicate properly. All right, so now we're going to go on to my second objective, and that's discussing the development of a risk analysis. So again, we talked about what a risk management is. We talked about how to communicate it is, to identify them. Now we're going to dig down a little bit deeper in here. These 5 criteria will steer you in the correct path. But like the slide says, we can identify risks. We can give you the tools. We can give you the training. But at a certain point, you still have to, as an individual, have personal responsibility for the actions you take. As long as you as a leader or you as a person or you as a healthcare system has provided all the stuff that I talked about, the tools, the training, the information, remove barriers. Sometimes people still are people, and you can't take risk out of being a human. We're humans. We're going to make mistakes. What I've said in years and years of being in leadership is everybody makes a mistake. But if you keep making the same mistake over and over again, that tells me something. So that's where we need to adjust our thinking a little bit and go, why do you keep doing this? So don't be the polar bear and slip on the ice, even if it says watch for ice. Next one is, again, these 5 ones. These are your take-homes. Identify the hazards. Where I typically see risk assessments go wrong is, and I call it solution bombing. There's a problem. Something happened, and we go, that's what we need. Damien needs more training. David needs to be written up. If I write David up, he knows that he did wrong, and he's going to correct his behavior. Well, wait a second. Hold on. Let's stop before we come up with a solution to our problem, to the risk, and identify what are the hazards. Whatever those hazards might be, let's take some time to dig into them. Because, again, some of these hazards you may discover you didn't know there was a hazard, like that burn pit. But yes, was there a hazard by keeping biohazardous waste and food and trash all in basically a huge trash pile because we had nowhere else to put it? That's definitely a risk. But there's also other risk of breathing in that burn smoke for months and years. So identify all those hazards up front. And some of them you can just flush them out. And some of them you're like, oh, that's new. I need to address that. And you can think in our sterile processing world, what are potential hazards? And again, we typically think hazards. I'm not talking MSDS. I'm not talking chemicals. I mean, it could be, but its hazards could be, again, not having enough light in your decontam department and you can't see what's in your sink and you get stuck. So if you start seeing an increase of needle injuries or stick injuries, we shouldn't have needles, but sharp injuries, because a lot of our instruments are sharp pointed, but the staff members put their hands in the sink and they stick them. The hazard might be, obviously we got sharp items. Obviously we got underwater, but maybe there's not enough light. So that's a hazard. Illumination could be a potential hazard. So identify all these hazards before we go down that path, because what I really hate to see people do is go down a path and then they identify the wrong solution to a risk and they really have the same risks there that's been there the whole time because they didn't identify it. Now, deciding who might be warned or harmed and how. So again, this is kind of goes back to my lean practice. Who's the customer? Downstream, upstream. Look at the entire process of what we do and what that thing, and go, who might be harmed? Now, obviously, in our world, who might be harmed might be the patient. And a lot of things we do, it definitely could be the patient. But it also could be the healthcare provider, or it could be our tech. If we have bad practices in our decontam department and they're not properly disinfecting or decontaminating those items and they make it to the clean assembly side, that person assembly may not know. That could cause harm to them. So the same thing as, we don't want to harm anybody. So decide who might be harmed and how. What would that harm be like from the hazards we identified? So if you've identified the hazards, then you can start talking about who would that hazard harm or who would that hazard potentially impact, because all these are these things. And what I do is I love whiteboards. I love the big sticky pads, those 3 feet by 4 feet sticky pads you can rip off and stick on a wall. And I start just writing stuff out. And I also have my staff involved in this. So I will literally write down these 5 things right here when we have a thing and said, who else can be part of this? Can you identify some hazards? Can you identify who might be harmed from these hazards or from this process? So again, take our modern world. If we're going to reprocess N95 masks or reprocess gowns or wash instruments that have potentially contaminated with COVID on them, who might be harmed? What's the hazard? And then have people write all these things down. And we really want to go through each and every one of those and make sure we didn't miss anything, because these will really show you avenues to go down, resources to get, because you might find a resource in there that, oh my God, you've never seen before. The next one, evaluate the risks and decide on the precaution. So again, you're going to evaluate what risks are really there, how big is the risk, and then how much precaution do I need to take. A lot of this is defined. We have great standards out there that defines a lot of stuff, whether it be OSHA, whether it be the EPA, whether it be AAMI, whether it be FDA, CDC. There's a lot of people out there that already have evaluated these risks and decide on what precautionaries we need to do. Sometimes there's not. And so that's where we got to dig down into that. We'll talk more about that in a little while. Now, I'm big on data. Anybody who knows me knows I love data because I can swing decisions, I can change minds, I can influence dollars by recording what we find and implementing the plan. Because if it's not written, then it really doesn't matter. So you've got to record your findings, you've got to implement the plan. And then because if you do something and you're looking at your initial state data, and then say 2 months, a month goes by, and all of a sudden everything's completely changed, did it go change for the good? Did it change for the bad? I don't know that answer. You have to help me with that answer. But if you don't have your findings recorded, you don't implement them, and you don't monitor them, it doesn't matter. And that ties into review your assessment and update necessary. When I say review the assessment, review that your hazards are still your hazards, because again, you might have changed the hazard. You might have changed who knows what it is. You want to review your assessment because our world changes as we did in this COVID world. I can't tell you how many times I've read something and said, okay, this is the path I'm going down, and bam, it's now a different path. So now my assessment is no longer good. And sometimes there's influences from your hospital, your healthcare system, your state, your governor, your county that change how you do things. So now your assessment is completely different. So I'll kind of give you one of my last slides is my modern COVID world and what's going on in our hospital, our community. But that's why my risk assessment may change. And I wouldn't know that if I don't review the risk assessment and my analysis and update it as necessary. So again, we talked about that. But again, I want to really talk to us because, again, you're seeing the same trends. We identify the hazards, and then you speak to your employees. They may be hazards that are not so obvious to you. And again, this is an old lean practice, is go to where the work is at. You know, I work a lot in offices. I'm on a phone calls all the time. My team will tell you it's just, they say they feel sorry for me, but I don't think they really do. But it's amazing that if I don't walk the area, some people get used to the hazards, and they just get used to them throughout the years. I mean, I saw at one of my facilities, the floor was bubbling up a little bit. Well, I asked them, I said, well, why is this floor bubbling? Oh, well, the linoleum, they didn't put it down, and this has been like that for years. Well, that could be a trip, that could be an infection prevention, it could be a hazard of whatever kind. So one of the first things I did is engage with my facilities department and say, time to fix this and get a new floor, or fix it or get a new floor. And guess what? I actually have a meeting tomorrow with a contractor to address it. But if people living in there, working in there, didn't even realize where that was a hazard because they just see it all the time. Or if I didn't walk the area, I hadn't talked to my people, I may not have known. So I got to do that. The next one is watching people do the work. I'm a big fan of watching people do work and listening to people, because you can't tell me that when the boss is on the floor, everybody's doing everything the same as when the boss is not on the floor. Absolutely not. But the good part is you can actually get a feel for your employees and how their task is carrying out. I'm not trying to find someone doing something wrong. I'm trying to look and go, wow, that looks really uncomfortable. That the way they're bending over that desk or that sink or whatever, I need to help them identify that and fix that out. So again, observe them doing the work that they do, but you can't do it unless you're out on the floor. And again, read the instructions for tools and equipment. They'll inform you of hazards. Now, the unique thing I can tell you about the world we live in right here, I have daily huddles multiple times a day with all the managers in the hospital and the healthcare system. And we're talking about everything from staffing to PPE to everything. Well, one of the things we're experiencing now, and it's a risk, is we're running low on certain types of wipes. So certain types of PDI wipes, the purple top wipes, if you know what I'm talking about, we're running low on those. So the risk on that was we're running low, but who really needs them? Well, the COVID floors need them for sure. That's what our IP said. So, but then you got a non-COVID floor. So I'll just, cafeteria even, just say non-COVID identified as that. Well, the risk is we could run out of the purple top wipes. But the next thing is they said, well, now you're going to get to use bleach wipes. Okay, cool. But we need to read the instructions, the IFUs, not just on instruments, but on equipment. So again, that's where one of the benefits on the OneSource is being able to not just look up instruments, but also look up equipment and say, hey, I was able to look up this machine that's on the floor or this unit and say, can it be wiped with bleach? Because it could ruin some of this equipment if we're not wiping it down the correct way. We get so stuck in our world of sterile processing and IFUs for surgical instruments. In this modern world, we got to look at that. But I'm listening to people that I've never heard talk about dwell time, contact time, proper aeration of stuff. I mean, these are nurses and respiratory techs, and it's just hilarious. Lab techs. and they're speaking my language, they're speaking our language, they're speaking IFUs. They're like, did you read the IFU before you apply that wipe to that EKG unit? Did you do the? It's amazing. So the nice thing about it is reading those instructions can inform you the hazards to that equipment. Because remember, it's not always a hazard to the person. You can also ruin that device by improperly cleaning it because you think you're doing it right. And that goes with the N95. That goes with anything that we do. Check the information contained within the safety data sheets. Because again, now we're using different chemicals, and chemicals don't want to mix with other chemicals. We don't want to have adverse reactions to chemicals that we're applying on one unit, and then we're applying a different chemical over it, and then there's a chemical reaction, a smell, a burn, whatever it might be. So please take a look at that too. Extremely important. And then again, consider the other situations. There's problems with equipment, machinery, maintenance, cleaning. All these play into the fact of identifying a hazard. If you have a machine that's down, what do you do? How do you work around it? What's the down? Can it be used even though it's got an issue? In most of our world in sterile processing, no. If you've got a washer that's failing its daily wash checks or its washer verification, that's not something you do a workaround with. But is it a wash rack? So maybe you can take the wash rack out of service, but the washer, the mechanical washer is still valid. So again, identify the situation. So not everything has to be thrown out or put out of service, but you need to look at it and make sure you've identified the proper hazards so you can communicate that up to the leadership. Leadership appreciates that. I love hearing, well, this has been broken for years. Well, did you tell anybody? Well, no. Well, then how can I fix it? So help me help you, help your staff help you as well. And if you're one of those staffs, please move it up. Decide who might be harmed and how. Again, we talked about the workers. The one thing, this is kind of divided by OSHA and some other stuff. So newer expectant mothers, we know that there's a risk associated with pregnancy and or new mothers and their newborns. People with disabilities, they have different immune systems and different ways of doing things that they may not understand. So there is something to be taken away from that. Think about the people who might not be in your workplace all the time. So a good example is your maintenance guys. If I get on my maintenance guys, come and fix, come and do this. Vendors are in your area. So are your visitors, your vendors, your contractors, your maintenance people, who else is in your department? Your EVS people who are cleaning your apartment. What is a risk to them as well too? So again, I kind of go back to the simple things of not enough lighting. Well, that can impact a lot of people besides sterile processing people. When I talk about looking at COVID type of situations, it's really interesting when we dig into, where are you going to process these things? How are you going to mark them? How are you going to identify them? All these things play into it because who's coming in that room? How is this done? So please look about who in your workplace is there. And then public, again, so are we saying everything we're doing is good for the public and then our healthcare workers are going outside to their loved ones? Or more importantly, if the stuff we're doing in sterile processing, could that hurt a patient and then impact the loved one's life? I mean, I've got some stories of where sterile processing has failed completely at their job and their duty, and there's been a negative impact to the patient, thus a negative impact to their life, and how it's impacted their loved ones has been amazing. I'm talking loss of job, loss of relationship, loss of pets. I've seen it where someone couldn't take care of their pet anymore and they had to give their pet away because of a negative outcome in surgery. So take the members in the public to account. Don't just think about you and your world. And then again, lastly, ask your workers, is there anybody else I missed? And that's why I like putting things on the whiteboard and putting things out there. Who else would benefit from being, identified as potential someone that could be harmed? So really look at all that as a key player. Again, record your findings. So identify and rank your potential risks. You're going to find potentially there's a lot of risks out there and there's a lot of threats, but they don't all bubble up or equal the same. So the key to that is honestly really identifying and ranking them. And that's a tough thing to do because where I told you before, one risk may mean more to another person. So that's where you have a team together. You have your IP, you have your risk team, your quality team, your legal team, your OR counterparts, maybe your vendors, bring them in. Bring in people to really look at what these risks are and help you rank them. And then identify how vulnerable you are as a company, as a department, because again, there are certain things we do that are inherently risky, and it's understandable. I mean, it's part of what we do in sterile process, what we do in surgery, it's what we do in health. So, all that. And then estimate the total impact of risks. So again, what are the risks? how severe are they, and then how vulnerable are you or your department, and then that will give you kind of a whole estimate of your potential risk. There are some great risk assessment tools out there. Amy has some in ST79. There's also some in some other documents as well throughout the Amy world, as well as ISO and a few other organizations that has really knocked home what a risk assessment is. But when you get done with it, it helps you boil down or really say, okay, here's the estimated potential risk or impact of this risk. Because certain things you're just not going to be able to say. If there's no risk, there's risk in doing it. But is it acceptable risk? Have we done everything we possibly can to mitigate the badness that could happen from that risk? And then annual reviews. So again, look at what's going on, and not just your world, look at what's going on. Changes in legislation, I can tell you that's a big one. On the ISHM side of things, we're looking at legislation in 4 states right now. And if a change in legislation happened, we got 4 states that are requiring certification, and potentially another 4 coming in the next couple of years. There's a lot of stuff going on. Significant changes to the task. Well, we know in our world right now, our tasks have changed, and we've been asked to change with them. There are some of my counterparts I've heard around the country that said, absolutely not, I am not doing X, Y, Z. I've been called Mr. Amy, Mr. Standards. I've been called a lot of names, but I've been called a lot of things. And then people go, well, Damien, how can you possibly do something that's not in the standards, that's not covered by anybody? Well, again, I did a risk assessment, and I go, there's significant changes in what we have to do. And the reason why is legitimate. So we got to think outside the box a little bit here, but we got to weigh everything into it. And then improvements you made. I love to see the improvements made. So you can show people our value in sterile processing by what we do. A good example is, well, I'll share it on the next slide, but it's really about showing that we're more than just processing surgical instruments. We're your experts for disinfection. We're your experts in decontamination. We're your experts in inspection. We are your partners in this, and it goes far more than a stainless steel instrument. And then obviously you want to say if we're doing something new and something that has risk, is there problems arising from it? Did processing these N95 masks cause an inadvertent problem? We didn't know. You got to monitor that. All that has to be monitored and be very transparent. And then finally, accidents or near misses. This one's kind of tough because a lot of times we catch things in the department that never make it to the customer. How do we address that? Do we, write a report? Do we talk to the person? You guys have to figure that out on your own in your own departments. But what I want to share with you, don't ignore those. I was called to a hospital a couple of years ago that was having significant problems. And what they told me is, well, all our written reports from the customer, the OR predominantly, they're not bad. But they had, I'm not kidding you, when I say 1 foot to 2 feet of internal reports, audits of dirty trays, of trays built wrong, missing integrators, missing instruments, critical instruments that are missing. I mean, they had 2 feet of reports, but they were in an office and nobody was addressing them. So if you have a near miss or an accident, don't ignore it just because it doesn't make it to the customer. You still have to address it, but you got to address it in a different way. And a risk assessment and all the tools I told you will help you get there. That's the beauty thing about it. Okay, now I'm going to dig into kind of more talking about me, my situation. Our situation is sterile processing. Our situation in this world that we live about. And, I've been on a couple webinars and I talked about, what happened the day I got the phone call that, we're stopping surgeries. What I can tell you about what's happening now. So I've already told that story in the past. What I'm going to tell you about what's happening now. In the state of Colorado, our governor has released the, the halt on elective surgeries. So starting yesterday, we've opened up elective surgeries in our healthcare system and more importantly, in my hospitals. So we had to do a risk assessment on this situation. So we went from doing typically 30 to 40 surgeries a day at each place and at about 10 to 15 surgeries a day at a surgery center. Surgery center shut down. It won't come operational again for a while because we had to take all the equipment out of the surgery center and put it on the COVID floors. So the beds, the monitors, the anesthesia machines, they're gone. It's been drained. So we can't go back there. So that risk has been mitigated currently. But in my 2 larger hospitals, going from 30 to 40 surgeries a day, going down to 5. That's what we were doing, only urgent emergent. Now they want to add in 30 to 40% of our normal volume and say, okay, Damien, go. So I had to look, what's the risk? So what is the risk to my staff. Do I have enough staff? Because what we did in our department, we also redeployed people. I'm very fortunate that I have a very flexible staff and a team that sees the bigger picture, and we're able to put them in other areas of the hospital. We're able to put them in respiratory therapy. I've got staff that are deployed to RT as runners, so they help bring down RT scopes. They help wipe down and clean RT equipment. They help restock carts. They're up on the COVID floors, getting things going for the next patient that needs to go on a vent. Well, again, when I told you earlier, that makes us there was a risk for them. I became part of the solution. Well, now there's a risk for me, because now when we start ramping up volume, do I need to pull these people away from the COVID floors to come and help my department? How do I do that without compromising the work they're doing? So those are what we're looking at right now. At what point do I say this surgery is too much for us, for the volume that we have? Plus, we're still pre-processing in 95 masks, so that takes time and staff away as well. So we're looking at the whole big picture here. And that's our current situation, is the ORs are awakening back up, which is exciting, which is what we're here to do. I love my staff doing their job, but we got to be ready for it. And that's our current situation we're in. And we could have a rebound. We don't know. I mean, this is all still new. So everything we do is based off, do we have enough PPE? We're starting to run out of face shields. We're starting to see some early back orders on Blue Wrap. I took great steps with my team, early on to mitigate those so we can last for weeks and weeks. We've got a lot of supply, but if they run out, what do we do? So we've come up with some creative solutions, and one of them is we got these, lack of a better word, welders face shields, but it's all clear and it surrounds your head, kind of like a PAPR mask, but they can wear those in decontam if they choose, and they can be wiped off and they can be reused, or we can use our mask, but if we run out of masks, that's what we got. So we're looking at different avenues, and that's our current situation. The one thing about risk assessment and sterile processing now, we'll talk about the stuff we do. There's been a lot of discussion, and my good friend Dave, Allie, Steve Adams, Tony Thurman, I can't even mention, there's so many people out there, Sharon Green Golden, that I can mention off the top of my head. I know Harry Mullins is on the phone, but we talked about in other things is how do we address potential contaminated surgical instruments, scopes, equipment, whatever it is, come into our decontam room. Well, we know through science and through facts, it's not Damien's opinion, nothing in here I'm giving you is Damien's opinion, unless I say this, is that COVID's not hard to kill. With our current chemistries, our current technology, our current processes, no different than a lot of the other bugs that we have in our department. In fact, there's other bugs that we see and don't see that come through our decontam area that are far more dangerous. But what's really cool is if we follow the universal protocol and the universal standards as we know them, we should be fine. What scares me is we know people maybe take shortcuts. Maybe they don't brush under the water. Maybe when they have an air gun in decontam, they're blowing air out through a lumen, but it's aerosolizing everywhere. Maybe they're using that big industrial spray gun that you've seen like in kitchens, and they're just hammering, that DeMayo boot or that tibial triangle, and they're just going nuts on it and doing that. So we know there's things we should do, and we know there's things we shouldn't do. And I think the COVID world has really highlighted to a positive that we need to follow our practices. We can't take for granted that everything's safe. And I don't care whether it's a newborn or a 90-year-old. Every instrument that comes to us, regardless of the patient, is infected and contaminated with something. That's my thought process. That's a Damien thing, and that's what I try to relay to my staff. So when I see people in decontam not following the training that we have provided as a department, as an industry, and as a standards organizations, then shame on them, and shame on me as a leader for allowing that to happen. We've got to correct that. Luckily, I've got a great team that understand me and understand I push hard on that. But that's what COVID's really done to our department. And again, COVID outside our department. One thing that was amazing is realizing how many departments really depend on other departments to do the job. We understand that we're very important to the OR and to a lot of other clinics, but when you actually have departments struggling, and I'll give you a good example, is we know in the ICU units and we know in all these other units that they have to put on this PPE, they have to put on all their stuff to go into a COVID ICU. Well, that's not their typical job. I mean, they didn't sign up for that. They haven't been taught that stuff. So we've redeployed a sterile processing person to these different units with other people and with training, and they are PPE specialists is what we call them, but they're watching people don and doff PPE. And sterile processing, and now outside of our department and other departments, is watching that process and going, hey, make sure you're doing this step first, this step next. I've watched you. They're tired. They're sweaty. They want to move on to their next patient or go home. But we now have sterile processing department helping them and say, hey, can you make sure you do this correctly? That's invaluable. The other thing that's been eye-opening, I mentioned a little bit earlier, is IFUs. Most of them never even understood IFUs. I had one person that says, he always told me, I sent you this, and how come it's not back right away? Well, you're not the only person we're working on, and things take time. But now they start to understand that there's actually IFUs to disassemble ventilators, disassemble anesthesia carts, disassemble whatever you just have to properly clean. And they are understanding, and they want to know how to properly clean stuff because of the fear of COVID outside of sterile processing. So we're helping educating them. We're showing them OneSource. We're getting on OneSource, and we're pulling up these IFUs for equipment that honestly I never looked at, because I never had to wipe down a ventilator before, but I had to do a lot of research on it. And then if they have to send the ventilator parts down to sterile processing for disinfection, what does that entail? Well, that's all inside their IFUs, but I never knew how to do that. I do now, and my team does, and that's invaluable. And then PPE and beyond, again, we can talk about this till the cows come home. We don't know. I'll be honest with you, folks. There's some great stuff coming out there in the industry. I've been working with leaders around the world, literally, and everybody is trying their hardest to crack this problem for us, to help us come up with a solution to the supply chain, to the reprocessing thing, to what is the next N95 thing we're going to run out of. Is it blue wrap? Is it face shields? Is it booties and decontam? What is that beyond? What's our world going to look like when this all happens? What's our world going to look like because right now, again, we still have COVID patients. We got full COVID floors, and we're still now doing surgeries. So we've got to figure that out. Do we have enough PPE to do it? How are we going to operate in a COVID world nowadays? Because it's not going away. TB, hepatitis, HIV, none of them are gone. We just learned how to work around them, with them. And we will learn to work with it. But we need to be smarter about what we do and how we do things. And we need to have a little bit open mind to trying things that just because they're not in the standards, they're not covered in anything, doesn't mean you can't do them. You do them through a proper risk assessment. And that's what I can tell you guys over and over again. Please don't just be the department and know because it's not in a standard. Be a department of, let me look into that for you. Let me see what the expert says. Let me phone a friend. There are, this is the 4th series of the Speakers Bureau. You got 4 people that you can call questions and send emails and ask them stuff. There's consultants out there that are more than happy to. You don't have to make this decision in the silo, but a risk assessment, performing it properly, will allow you to give those people a lot of information, a lot of data, so they can help you with a decision, both inside and outside of your department. So, that's just, again, a little bit about me, a little bit about our story. What I really want to go into now is, really what I want to say is thank you to our healthcare workers out there. All healthcare workers, our EVS techs, our kitchen folks, our biomeds, our facilities, obviously our nurses, our doctors, our techs, our sterile processing. And thanks to the families. I can tell you my family has put up with me, friends have put up with me, and then our community. When I talk about community, I'm not talking just sterile processing community, which is huge, but I talk about our community as a whole that really support us. The community, the community of humans around us and people around us supporting us doing this work, providing food, providing notes has been uplifting, and it's been amazing. And obviously thank you to OneSource for putting this on today. And finally, the last slide we're going to go to before we open for questions is, again, you will receive 1 CE for this. You can go to this site right here to get your CE. And then the presentation in a couple days will also be online at onesourcedocs.com.